Good morning and welcome to our monthly webcast. I am Samir Mehta, your moderator. This is session number 203. We have an exceptional teaching case for you today, a calcified distal left main bifurcation lesion. We'll wait to see whether the left circumflex is involved, but you will foremost learn today what should be your approach. Should it be a stepwise provisional stenting or an upfront two-stent strategy? All these questions, much more about lesion modification. Let me take you to the cath lab where Dr. Kinney and Dr. Sharma are scrubbed in. Samin, Anu, good morning.
Good
Good morning.
morning, Samir, and of course, welcome to our CCC live webcast viewers, which the number keep increasing, and we are so happy. Both actually India and America, anywhere you go, both these continents, and so people are so happy and thank us for this remarkable educational experience they get, and of course use them quite a bit in their day-to-day routine. As you said, usually we have taught about mini crush with a distal left main bifurcation with a two-stent strategy, but this case will be a little different, and we are planning to make it single stent, and let's see how successful we will be. Anu, you want to say anything on this?
No,
Let's
please
see the
proceed.
angiogram.
I mean, this case
Hmm.
truly complements the left main from last time when
Yeah.
we were dealing with the diseased left circumflex as well.
Yes, that is true. And it looked clearly that time, and we did the imaging that was not significant. In the end, looks a little hazy, but was good blood flow because there was some left main dissection. We left that alone. So this is a little kind of different, similar experience we are going to go through, and educational points.
So you see the right corner, you can see the EDP was normal, EF is normal, and right coronary artery had a significant lesion which has been taken care. And you can see the tram track calcium of the left side right now.
Center.
Yeah,
Yep. Look at the calcium.
yeah. So I think what is the teaching point we say is if you're already angiographically seeing that kind of a tram track calcium, there's no indication to do imaging at this time. Do any kind of atherectomy that you're comfortable with. So we'll be doing rotational atherectomy. I'll tell you one other thing. So this is the cranial again. So there is a mid lesion before that, two small diags. And then look at this,
Wow. Look,
ostial LAD.
This
and that.
truly is the real telltale view.
That's a
Okay.
calcium nodule.
Yeah.
Right.
So there we are. So we did not do anything. We did a wire with the fielder fine cross, and we are ready with 175 bar. It,
Question
and
would have used a 2 bar versus 175. I think this is a large calcific nodule. Probably will require combined strategy,
we have
and that is
IVL ready also. So
uh,
what will we do? We'll do the rotation attractive 175 bar. Then we will wire the LAD, and after that we will take care of the um, mm, we'll do the imaging. So if you see, though in the first view, we didn't see a circ lesion.
yeah, there is a very tight lesion in
Yeah,
the circ.
there's a very
Yeah.
significant disease in
You
the
don't see
circ.
it here,
Yeah,
but in
you
the other
don't see in
caudal
other
view,
view.
you see that
Yeah,
in my announcement, I made it. There
yeah.
is a three vessel disease. RC has been taken care. There is a 80-90% circumflex, and there's the LAD.
Yeah.
So with that note, let's go to our presentation, please. We
So,
start. Yeah.
Samin,
Yeah.
quickly, Anu, educate us once. Somewhat short left main was what was your approach towards selecting the guide?
Okay, yeah. So short left main. The thing is same. If you see in the, we took FCL guide just because most of the disease from the old picture was all in the LAD. So FCL is usually a guide that helps you, if you have just LAD disease, see this short left main. So when you have short left main, it's okay that you can go with the FCL, FL. FL guide does not give you a lot of support at all. So FL guide is we prefer if there is ostial left main disease. So placing of the stent and all that is much better. So we took the FCL guide. Normally you see us with VL guide. So this is a C curve. We got to make sure we'll be able to get into the LAD, which is at this point here.
Yeah.
Samin, two other important questions have come up. Number one, why not surgery? Number two, despite the LV being normal, but there being critical left main ostial LAD, possibly circumflex, why not an impella?
Yeah, so that's a very good point. So in this case, it's a little more complicated. Patient also has mild to moderate aortic stenosis. Although once the valve area is more than 1.3, in the trials, anything more than 1.2. Wait 1 second. The more than 1.2 was not a contraindication for impella trials. But in this case, for that region and good left ventricular function, good circumflex, RC has been taken care. I think based on all the definition, this case could be done as a standalone without impella. Of course, if some trouble happens, which is very rare, then you use impella. So this case is not for impella because of, if you think about, it is a straightforward distal left main ostial LAD. I know there are other lesions in the circ and mid LAD, but this one I will not call it a real complex bifurcation distal left main. These are the same. Case number 203, as you said, patient has mild to moderate AS, 70-year-old male. Question is, could this patient go for surgery and get the surgical valve replacement and get the cabbage? But overall, a lot of discussion happens with these patients. And this patient had a cath, normal right heart pressure, mild AS, 1.3 centimeter aortic valve area, and calcified 3 vessel and left main CAD, which you have seen here. So question was, we fixed the right, now brought for the left main bifurcation, LAD circumflex lesion, distal or whatever OM we call, but there is no ostial circumflex lesion. And plan is, first time we will say that we are going with a single crossover stenting. Now this is in our left main 2 to 3 vessel CAD. Again, patient is on single beta blocker. Not on 2 anti-ischemic, but still, after discussion, this is an appropriate case for intervention. Okay, ready now?
Yeah.
And we are ready with the 1.75 bar. Question is 1.75 for 2 steps have been taken care. Yeah. And you saw the hemodynamics, no change, very nice advancement, slow, no jumping.
As elegant demonstration of rotational atherectomy as ever. Wonderful job.
And we are two fellows here, Neil Kumar and Prithvi, and our same CVT, Asif and Naira, and our nurses, Will, Aldina, and of course, imaging Kiski when we need. Although Kiski probably wants to do it right away, but we probably doing imaging a little later. This is the mid LED now. Yeah, that's okay. Keep going. Yeah.
Good. Okay. I think they're good, right?
Yeah. Good.
So he has been on Plavix. So if you see the PRU is a 10, so I don't think we need any strong antiplatelet agent.
Anu, a question for you. This is, I'm not able to know who's the person asking. Considering the ostial lesion, any role for the rota ES wire?
Extra support, yeah. Nothing. I mean, here, if you see most of the disease was in ostial LAD. Yeah, if somebody says I want to do extra support wire, that's okay too. But we use rota floppy.
Yeah. So extra support
mostly,
wire.
True ostial disease of the RCA, where you guide is actually not in the vessel, where I call it as zip lining. Zip lining rota. It's called, where you have guide not engaged, you're far away, and rota has to go on the wire without engaging the guide in the vessel. So that we call a zip lining. And that situation, yes, you need extra support, definitely extra support.
So very simple answer would be that, as Anu mentioned, that in aorto-ostial, extra support is reasonable. In non-aorto-ostial, I think it should be floppy because that can cause significant wire bias in one way versus other.
All excellent questions coming in. Here is another very specific one from Dr. Mohammed. I know he's been with us several times before. I'll read it exactly as he mentioned. Of course, he first of all said, good morning, great team. Yeah. Shouldn't you advance the burr while pressing on the brake defeat button and a second operator fixing the wire.
Yeah, so that's a very good point. So question here is that by changing the direction of the wire, you may be able to do more ablation, kind of becoming little orbital uh, atherectomy rather than just the rotational. So question is in the short lesion, I think it's probably less of important, but yes, time to time we do pull back the wire, and idea there is that you are changing the direction of the rotor burr and making the, with the wire bias situation, they're trying to ablate different areas. And so, yeah, yes, but in the longer lesion, I think the short lesion is very straightforward. And I think this case would have been even 2 bar, but we had the 1.75. You need a cutting balloon. What do you need now?
Imaging.
Oh, okay.
You also mentioned it, Samin. A
Take the rotor wire
question
out.
had been asked, would you consider orbital?
Yeah, this is okay. Reasonable case for orbital. Yes, in aorto-ostial, we have published that orbital is not good. All the people say that you manually advance into the vessel and then start the crown and then pull back, like retrograde orbital atherectomy. But we don't do it. So yes, aorto-ostial, no orbital. In non-aorto-ostial, like this case, orbital is completely fine. You take the rotor wire out.
So Samin, is
This
this
is-
your prediction? You'll find a nodule there?
Yes, yeah. Well, angiographically, it's a big nodule, and we are starting with the mid LED where there is a lesion also.
It's coming.
Yeah.
Yeah. 273, 60
Look at this
calcium.
concentric calcium.
Yes. 360 diffuse calcium. Yeah, some calcified nodule I see.
390 degrees.
Some bifurcation, ostium and left main. Very short left main. I will stop it. Yeah.
Okay. Tell us, Kiski, exactly the lumen which we expect, the mid LED full calcium circle.
Yes.
But tell us about the nodule at the ostial LED left
Sure.
main combination.
Sure.
You want to put a wire in the circle?
Yeah. So now
Yeah.
this is the left main, and we see the
And the-
circ from the 10 o'clock just inside this. So this is exactly the ostial LED. It's very tight.
But it does not look like any
No,
extra
there's
calcium, I mean nodule,
not
right?
even that. There's no nodule.
Huh?
No nodule.
No nodule, yeah.
Yeah, eccentric calcium and a
So it's
very
just eccentric calcium, Samir, based on the imaging, we have to say it's just eccentric calcium. There is no true nodule.
Yeah, but when
So-
we go a little bit inside,
Mm.
yeah, so like here, a little bit protruding inside and the
Oh, there,
irregular
yeah.
sulfate.
So it is there. So just below the ostium, yes.
Now
Yes.
go back to the true ostium
Sure.
and how much is what's the okay? So
This is
it's
the
almost 3 quadrants, right?
Yeah, real ostium is the like 180, but a little bit inside, it's gonna be like, yeah, 270
So-
calcium.
So I think that the nodule is just there inside the ostium with the proximal LED. So we
Yes.
angiographically look like, oh, look at the nodule here. Yeah.
Yeah, this is
So
nodule.
Samin, many operators looking at this image will say, maybe make another run with the rotablator.
The bigger
no,
bar,
no,
you mean?
no.
That's
No,
one.
yeah, because it is still a lot of calcification there. Still, no, I'm sure a certain amount of lesion modification has already occurred.
Yeah.
No.
So
So
what
let's
I would
go
say-
back.
Yeah.
Let's go back.
Okay.
Kiskit,
Yep.
show us
Yep.
that rotational atherectomy has done its job. Can you just show it with your arrow there? So
So-
now if we need something, we have to decide,
Mhm.
do we do IVL or do we do the cutting balloon?
So the ostial LED still
Mm.
very tight, and the MLD is still 1.5.
But have we caused any crack? Have we caused the cuts, or cracks in the plaque?
Not clear crack or something. Maybe this is the natural feature of the native calcium, and it should still very tight. And the 360 calcium, like here, no fracture.
But that's a cut, no? Is that a cut or no?
I don't think so. So I see some revalvulation from 3 o'clock. So the
Hmm.
surface of the calcium is shaded by the rotor, but I don't see clear fractures
Okay.
in the plaque to meet LED.
Good.
You
So-
don't see fracture when you do rotational atherectomy.
Yes,
if
correct,
you
correct.
need
So,
something
Yes, the
extra to be
different
done
mechanism
now,
shave the calcium. Yes.
yeah. So looking at this, I think we should do an IVL.
Yes.
3 point. Now take the rotor wire out. You have 3 wires now. So we have put a wire into the circumflex. So coming back to Samir, your question. So you probably heard that now I have made the point. Nowadays, in this day and age, with the advent of safety of the IVL, your second burr is IVL. Very simple. Either you use a 1.25 bar, whatever you use. If you want to get a second bar is your IVL.
Excellent, which was also a question asked by a few people about proceeding with the 2 burr. Instead, the second burr is IVL.
3.5.
Okay, hold on. No, go back. I think so give us a vessel size. 3.5 is okay,
I think
or
so.
we need 4.0.
No,
I think 3.5 is okay.
3.5.
Distal left main to.
Yeah, proxy LED is not for like 3.9 EEL, but mid to distal LED is 3.0 vessel. It's tapering vessel.
Okay, let's go 3.5 just because true ostium. Okay, give me the IVUS. Let me quickly do the.
And as right now, as you know, in the Euro PCR, they're presenting the data of the Bolt Medical, which is Boston Scientific. We were the lead enroller in United States, overall the second enroller in the worldwide, because we were allowed, I think 44 or so. And that looks very good data. And they'll go to the FDA and they expect before end of the fourth quarter that they'll get approval of the another IVL in our market.
Okay, I'm going to the ostial circumflex.
Sure.
IVUS.
How was your experience doing so many cases with that? How does it compare with the existing IVL?
So I think that it is more flexible. And secondly, setup is very clear. You don't have to get to those
Go.
extra
start
coverage
feedback. This is
and so
feedback
and
from
so
the
forth.
circ.
It's just basically you connect it. And so all these companies are working on that. How can you do
Looks wide open.
that each cycle less than 10 seconds, so that cause less ischemia. So even our current shockwave is coming with the 5-second runs.
Is there a lesion in the?
So this is osteocirc.
No. There is a lesion in the.
Did you cross that far?
Yeah, I did. Do you see anything there?
Yeah,
right.
I mean, start with the pullback,
Right there.
like
Yeah,
tight
yeah.
lesion.
Okay.
Yeah,
Now come to the ostial circumflex.
osteocirc is wide open.
Wide open.
Yeah.
Yes.
Okay.
Let's put a stent there. I mean, cut and then put a stent. 3O cutting balloon?
Cut where?
The circ.
Okay.
The same one the IVL will do for the LED left main, and we do let's put a stent in the circ first, or you want to do
I don't
IVL
know. I
first?
have a regular balloon. Why you want cutting balloon?
Okay.
Right?
Yeah. That's
that?
okay also, because why
There's
to put
nothing
a
there.
additional cost
Yeah.
into a little bit of calcium, but proximal, nothing there more. So you have the imaging there, yeah.
It
Okay.
really is amazing. There's so much calcification in the
3 or 12.
ostium and proximal
High pressure
LED
balloon.
and none
Yeah.
in the circumflex.
Yep, that's correct.
Yeah.
Oh, yeah.
What is it?
No, there's 20. Yeah.
Yeah, good. Let's hear.
3. No, hold on. Let me finish the circ. You just said finish the circ.
You're going to address the distal lesion first, no?
Yeah, yes,
Yeah.
circ, yes.
What strength are we doing? Science?
No, this was the synergy case, right? Synergy on the right side.
That's okay. We can do anything.
So whatever you want. Yeah.
Okay. 3.0, 3.5. Circ looks 3.5.
3.5,
16.
16. Yeah.
3.5, 16.
So now we are doing the distal, I mean, whether we call it a OM1 or so, and balloon high pressure, non-compliant balloon followed by stenting. So that will be our goal now. But this is 20 millimeter balloon?
No, 12.
Okay.
We had a 20
Good.
open for the.
Good.
Okay, go.
Can't even see.
Yeah.
Opened. Let me do one more.
Get us a 3.5, 16 synergy. After we do IVL, do I need to go way further down in the LAD?
Yes. Through the pullback or diffuse plaque.
Yeah.
Yeah. So LED, actually, you had to go to the mid LED there. See that?
Yeah,
You had
but
to
not
go.
the distal.
Yeah, you have to go there. But without, there's no calcium, but there is a tight region. Yeah.
Yes.
I
we
mean,
can't do
the
IVL
LED has not been stented before, has it?
Nope, it's all calcium.
Okay, all right.
And we saw that also on the IVUS. There was no stent and just all calcium.
No.
There was a question posed whether there is a stent and whether we are going to be talking about a drug-coated balloon.
No, but this actually, as you saw, IVUS was there. You want to show that LED IVUS
Go
again?
back and show
Yeah,
the.
yeah, there's nothing. Look at the whole circular
Yeah,
calcium.
no stent trap. It's a like natural stent. It's all native calcium.
Mhm. Okay, now.
Good.
So, Samin, just looking at the early IVUS images, mainly relying on the angiographic, what kind of
Fungi.
Good. Yeah.
left main area would you have a goal to have when
So
you're
now,
done?
yeah. So I mean, again, but ideally, so the 865, the combo,
But
but
I'm sure you
yeah,
have it much more in your mind,
yeah.
no?
In this case, yeah. So in this case, I mean, preferably if you
Some guy.
get 10, then there will be no restenosis.
Yeah, good. Okay, go up. Okay, 3-5.
Yeah. 10.
Good. Down. Go up again. IVL is ready. Okay. Okay, good.
And do you need a 3O balloon dilate further inside?
Of what?
This. Go.
No need.
Take a cine.
Looks good.
It looks perfect.
Yeah. Okay, IVL to the LED.
Samin, also, I mean, looking at the angiogram again carefully with the, again, IVUS did supplement that, not much calcification in the left main by itself. All starting from the ostium and the proximal LED.
Well, actually, you know
Some
what?
there.
If you
Yeah,
see
some
there,
there.
yeah.
Yeah,
So I
some
would
there.
still, by angiographically, if we had to assign, I would call it a severe calcium distal left main and proximal LED. As you saw when we did the MACE
Keep it,
trial,
keep it.
yeah, MACE trial. This is now the IVL. When we did the MACE, put it back there. Yeah, MACE trial. Jeffrey Popma was still in Boston that time, and what we did is we are all the operator to send their 5 films and labeling them as a mild calcium or no calcium, moderate calcium, and severe calcium. Very interesting that severe calcium concordance with the central lab, with the core lab, was like 98%. So that basically means that we know how to identify the severe calcium. Once you go to moderate, number goes down to 92, and mild was like 83.
2.
So clearly, so this I would definitely call serum. Look at that. You can do even bigger one. Yeah.
Remember I said 4-0?
Now this is the Aero, the more flexible IVL catheter, which is very good, but we found little more rupture of this because we remember balloon material became thinner, and that is what we saw. No, you have to leave it for a few seconds. Yeah. 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 Good. So let's go back again.
2 atmosphere and then you go up. Yeah.
And there are so many these IVL catheters are coming with a laser energy and you name it, just with the metal on the balloon, causing little high pressure juggling and causing the same fracture in the calcium. We can go to 4 now.
I did. Okay,
Want
go.
to take the guide out a little bit?
The thing is after this will go distal, okay?
Yeah. You see that now opening a little bit. It's still not fully open.
Yeah, but I think that's okay.
Yeah.
Stent will take care of it now.
The blood pressure does go down because this is we are inflating in the left main,
Okay,
and that is
go
exactly
up here.
precisely what all the companies are working on. That can you cut down
Short
this
ischemic
inflation
time.
time to the 5 seconds rather than 10 seconds?
Has anybody even thought about creating some kind of a perfusion balloon and mounting IVL on that?
That probably, I'm sure,
I should
all
have
those things are in.
applied for a patent before saying this, huh?
Go.
They all are working with various technology, and
Yeah,
why it
it's
is not
true.
fully inflated?
That is
So
the
much air.
thing. That's the other thing also we have noticed. There's a lot of air inside this,
Yeah.
no matter how well you prepare.
No,
Now
just
you
one
see,
sec.
wait.
One
Wait,
sec.
wait,
Yeah,
wait.
I know.
Air bubble has to come out. Okay.
You used to call burping. The balloon burped.
Okay.
Good. Now we are going to go to 4.
Go.
Ready?
Go up
Good.
here. I was ready.
Yep.
It'll be interesting to see the cracks now.
Yeah. All the data have shown, all the randomized trial comparing
Go.
rotational atherectomy with IVL. Now, what do you need? Oh, just same place. Okay. They have shown the similar efficacy, similar procedural success, similar MSA, except lower perforation rate with the IVL compared to rotational atherectomy. But an OA is inferior, particularly the Lesion is clearly inferior, which have been shown in few trials.
Samin, right
Yeah.
now here, would you go even a little more distally?
Yeah,
We
sure.
are
Because we had to
going.
put a stent in
Okay,
all this
there you go.
calcific area.
All
No,
right.
it's not going.
Yeah,
Okay,
good,
okay,
good,
good.
go.
Okay, good.
Okay, here we go.
This is the advantage of this arrow, where you can go again to atmosphere 3.
I think we are good. After this, we can come out.
No, but do one more at this place.
No, you have to remember
The
that
question always comes.
it's not a lot of calcium in the distal.
Mhm.
Well,
That give the
you
maximum pulses versus pulses you think like 3 or 4, you think the balloon has expanded and you just limit there. So this is
I'm
actually
coming
another
out
field.
now.
Huh?
I'm coming out.
No, just put an ostium again, once again.
No
You
need.
wait.
We've done
Do.
it.
Okay.
you extracted a lot out of a single device.
Okay, let's get the IVUS. What we have been noticing that if it is 180 or less than 180 degree of calcium and you're
Take a
doing
picture.
IVL,
Hmm.
it usually causes deep cuts, medial dissection at the angle of the calcium and the fibrous tissue.
And clearly, as I said, one other difference is that it causes more calcium fractures with the IVL compared to rotational atherectomy. The rotational atherectomy will just create one gutter, 1 or 2 only, while calcium fracture more than 2 are very common with the IVL.
So very basic foundational question again posed by Dr. Mohammed. I kind of understand where he's going from that, but he specifically wants you to explain how do you judge the amount of pulses needed to modify a specific lesion?
That's a very important point. So I can tell you there are some data that maximum pulses versus do those selective pulses when your balloon is fully expanded. Maximum pulses have shown to be better outcome. But usually, once your stent is fully expanded and you are done 2 times in that area, I think that's good enough.
That has
Yeah.
not been studied yet. That exact question. We actually are doing our own trial, nodule shock. Okay, to understand, do you have to give the entire, because the original teaching was that if the dog bone effect is gone, then you can, no need to give all the pulse. Okay, but question is it operator determined or you have to give 120 since you have the 120?
Yeah.
So one thing is that they're also saying even if there is a non-calcified area between the, if there's a long lesion in between tandem lesions, if you're doing IVL, the non-calcified area, nothing happens. But I think that's not what we are seeing.
Take a picture.
Look, I'm sure at the
Hold on,
back
let's
of
show
the
the
mind.
IVUS.
Sure.
Okay.
So now this is a prox LED. So definitely this is the calcium fracture
Okay,
at
good.
the 8 o'clock.
Okay.
And the ostial LED, it was very tight after the rotor, but now area is 4.9. And the MLD, it was like 1.5, but now it's like 2. So definitely lumen is bigger. Of course, with the IVUS resolution, it's hard to see the real fracture in the ostial LED, but lumen is definitely bigger than the
You don't
pre-IVL.
see fracture, you're saying?
Yeah, we saw 2
Say-
fractures.
I mean,
no,
yeah,
no,
some part like
not at ostium.
yeah, some cross section we see the fracture, IVUS resolution, but the osteo not clear with this resolution, but lumen is
Not
much
at the
bigger
ostium.
than the
They are
pre-IVL.
not cut.
So I think it's good modification.
Mm.
Through the vessel, lumen is much bigger than the yeah here and looking as you said, this is
Yes.
a like dissection
Mm.
opposite to the calcium part. So this is the IVL work for the also the non-calcium part. There's
So
dissection.
yeah, so keep it there, keep it there. This is exactly the point that I made, Samir, so that our viewers will learn something. See the calcium here, right? It's a not even 180. So see what it has done at the calcium. So can you show that arc? Just yeah, put that angle. So the arc you're seeing, nothing has happened, right?
Maybe
Yeah,
small
yeah, plus
fracture,
Yeah,
minus.
but
yeah.
I
also
mean,
yeah, at
based
the
on
edge of the
IVUS, plus
calcium,
minus.
the
But see at the at where the calcium is meeting the fibrous tissue, that is that deep medial cut, and that's what we have to be
Keep it
careful.
there.
Also,
Yeah.
it could be deep and can what we call is contained perforation, which we have seen many cases. You see that there? Yeah. Now go back to the proximal
So,
LAD.
Anu, that's a very delicate balance. No, in many ways, that is exactly the kind of a cut you want, but slightly going beyond gets you into trouble.
Yeah. See, when we are doing IVL, see, when we are doing rotational atherectomy, I still think the good old rotational atherectomy is very safe. How the physics principle works, there is deflection of the normal tissue when the rotabar orbits, right? It rotates, not orbit, rotates. When it rotates, there's deflection of the non-calcified. But here you don't see that. So when the ultrasound waves are going out, yes, if it is calcified. So I want to go back to proximal LAD so that we can say if there is 360-degree arc of calcium, that's the time this really works and should be used. And when you are not sure, just be very, very cautious. And we are, in fact, me and Kiski are trying to make this point that when you are using IVL and you have calcified lesion, you got to use 1:1 if there is more than 180, almost 260, 360, 280 to 360-degree calcium. Yes, that's very good. You can use 1:1. If it is not, if it is less than 180, try to go smaller balloon. Yeah. So now go back there. If you see that, what he's teaching, showing there where he has made a point. So that is close to, you see that? That is what we are saying is the fracture within the calcium plate.
Anu, explain that one more time. 1:1, I understand. But if the arc of calcium is less than, let's say, 270 or something, why slightly smaller?
This because we showed you. Look at that kind of a dissection you're seeing. You understand?
Got it.
So you
Got
are
it. Very
the
nice.
balloon is 1:1, and now the ultrasound waves are going, and we feel
Excellent.
probably you're causing deep medial dissection
Very
can give rise to the contained perforation, and we are saying try to avoid that.
excellent teaching point. I bet you observed it after 1,000 cases of IVL. Profound observation, hopefully very beneficial for the audience.
Yep.
Yeah. So one point that we want to make, I don't know whether we have enough cases to come out with this algorithm, which we always try to say, you know, which one you should use, either a kind of atherectomy device you have used, then you say, okay, do I use cutting balloon, do I use IVL, and if you are using IVL, what size IVL? Okay, the point is I gave 3 pulses, can I come out, or do I have to go back and finish all the pulse? That is difficult for us to come up with yet, unless you have done imaging multiple times. Give 3 pulse image, give 6 pulse image, and then we understand what this each of these 3 pulses are doing or 1 pulse is doing. That's really difficult to understand, but I think the study that we are doing, nodule shock, which we are almost more than halfway through, we should come up with some kind of an algorithm soon.
And actually,
Excellent.
nodule shock will tell us, which people always ask, do you combine both technique or one is good enough? And that is where there is a randomization of the IVL rota or IVL alone.
Outstanding.
That's
Anu,
your
great
picture.
demonstration, wonderful discussion. Samin, probably time for you to jump into your presentation.
Let's take a
Yes.
picture and let's tell us what stent you are using. Go to cord. No, this is okay.
No, we can
Yeah.
go here itself, right?
Yeah.
38. Let's go 30, and then
48. You have to go up to there.
Okay.
48.
But
3048.
left main is what?
Yeah, at least
Can I go 3.0 and then post dilate the left main to 4.0?
Yeah, start with the pullback, like the mid LAD is 3.1 Bessel.
Yeah,
and
exactly.
But the
Yeah.
proximal LAD is like a 3.9 Bessel, and the left main is more than 4 Bessel.
Okay.
It's a huge
So you
size
want
gap.
to go low pressure 3.5 or
3.5.
3.0 and high pressure? I
Yes.
would go 3.0. And
Okay, yeah, 30.
please.
That's okay. Give us a 3048.
I
Nothing wrong in
remember
that.
I go with the eyes. Bring here, show. EYE IVAS, please. Yeah. Look at what Will has there. He always has it. Where is he?
Yeah.
Can you see it?
Show the, yeah.
Focus on the
IVAS.
camera.
Yep. All right, let's put this stent and
Yeah,
then
you can go.
yeah,
You took
then we can-
48?
Yeah, 3048. Yeah,
Okay.
good. All right, so while
And
they're
4.0,
putting it and
4.0,
proximally optimizing,
4.0, which one? 15, right?
yeah,
You have to
we can
open
go our
4.0,
presentations. Yes.
yeah, go with your presentation. That's it. We will do the IVAS after.
Yep. Then you will show it. Yeah. Okay. So this was appropriate. Now let's go to our issues in the coronary intervention. One is the sum of the key interventional trials. Last time I showed the imaging, and this is the other one, Orbita CTO, FAST 3, all rise STEMI D2U. And focus review is the new that stent design, although they don't call it stent, they call it bioadapter, which is dynamics and implantation and 2-year outcomes of this very novel technology. So first is Orbita CTO. What they did is 50 patient placebo control, that every patient got the invasive, went to the vessel, half of the CTO were opened, other half were just left alone. And then have the angina questionnaire, and you know CTO PCI has become very difficult at this time for approval point of view, justification point of view, because it's only indicated now because many of the long-term trial of up to 5 years of the CTO PCI have shown no difference in the CTO PCI versus non control group. And that's why it is only for refractory patient or maybe large ischemia to improve symptoms. And what they did orbital, which is their master in it, that everything is on app based. So patients know about the angina symptoms, they're taught about it, and then a change in daily angina, ordinary clinical outcome scale, and they're basically taught after initial randomized, initial teaching, and then the basically randomized patients, a blinded follow-up, and restart of the anti-anginal medications, and then follow up this patient for 6 months. This was the 50 patient I mentioned. This was the Orbita CTO. Patient demographic, indication for CTO, more simpler lesion. Idea here was, let's be a higher success, and so that we can see what the results. The results basically what we expect. The CTO PCI improved angina symptoms and angina score, and although medication use was not different, and the angina class significantly improved with the PCI, more patients in the 0 and 1 compared to 2 and 3 compared to medical therapy. So this is a central illustration just to show that as follow-up, angina class improved and angina frequency decreased in patients with the revascularization. Second trial, all these are like, published in NEJM. So FAST 3, that was the fractional flow reserve, 3D quantification, coronary angiography based vessel FFR. And you can see here, we know that FFR is now class 1 indication and has shown that anything less than 0.8 or IFR of less than 0.89 is class 1 for revascularization guidelines. And so what is the, rather than you do the invasive, what about you can do by vessel fractional flow reserve, that proprietary technique that just by the angiogram that you can come up with FFR just like CT FFR. And the whole question was, if you combine this between two strategy, that is the angio FFR versus CTA, our regular FFR guided revascularization, various endpoints were similar, but various procedural characteristics, but key is that VFFR guided versus FFR guided revascularization, you can see exactly identical outcome. Somehow the p-value for the stent thrombosis was 0.1 different in favor of the guided revascularization P, but I would say it's not much different, but overall just to say that identical outcomes of the FFR versus FFR guided. FFR is the invasive, and this is just by the CT scan, and you can see the overall outcome, which is completely fine. So they basically showed that VFFR guided revascularization was non-inferior to FFR guided revascularization respect to death MI on revascularization at 1 year. Therefore, the question comes, what are we going to do now? Are we going to just change our physiology in the cath lab, or we still continue imaging and invasive FFR in this era of artificial intelligence? They're basically saying that you need to combine both. Many cases you can avoid the invasive FFR, which is good. Second, is all rise, also angiography derived fractional flow reserve by the 3D computerized system. Same, it is also cost effective. So FFR angio guided versus pressure guided. Same, you take a picture, based on that they clear the FFR, and based on the analysis, defer versus do the PCI, and overall showed no difference in terms of the various procedural angiographic characteristics, except FFR angio had different, same contrast volume, but definitely took less time compared to pressure wire FFR. The outcomes were exactly identical with various events as shown here, except that major bleeding, and I don't understand what exactly was. Why numerically FFR angio had a major bleeding of 0.3% versus 0.9 in the pressure wire, but rest of the points were all similar. Actually, AKI was also identical, and stent thrombosis also same. So only question was that there were definitely numerically lower bleeding, which is 30-day outcome in the FFR angio group. So again showed that another FFR angio is non-inferior to pressure wire divide strategy. So all rise trial does not serve to displace the pressure wire. Rather, it underscores a broader shift towards physiological assessment as the principal framework for interpreting coronary artery disease and guiding appropriate PCI. So basically, with these two trials of the FAST 3 and all rise, my conclusion was that angiographic derived FFR may increase PCI rates. So both of them were angiographic guided. It may increase the PCI rates because you can do now less resistance getting the IFR wire or FFR wire now just with the angiogram. It tell you about the FFR. So clearly it will increase and appropriately increase the use of our PCI in appropriate cases. And some cases it would be borderline cases you need to do a pressure wire and so. Then the fourth data, the trial I wanted to present is the D2U STEMI, left ventricular unloading in the anterior STEMI without shock. And basically the concept was that anytime when MI patient has a heart failure, could have death, and studies have shown that when you open the vessel, you have a lot of downstream embolization and free radical and distal vessel injury. So question is the infarct size could be decreased if you decrease the ventricular size, and that was the whole concept based on the ischemic time and 1 year mortality. They did a pilot study which was no difference, and I'm really surprised at that time when the pilot study was presented, D2U pilot, there was no difference in their 50 patient trial, but they still went ahead and did this major trial of the STEMI D2U treatment versus control. What they did is in the treatment group put an impella, left it for 30 minutes before PCI, and then you did PCI and leave impella 4 to 24 hours after PCI, and the follow-up up to 90 days and 6 months and 1 year. More importantly, 6-month cardiac MRI for LV function and the clinical evaluation. And this is basically the run through of the program with the patient flow. Other times were all identical except the time. The time in patients who had the into the treatment group, as we know, because you had to wait for half hour. So this clearly was extra time into the treatment group compared to control. But the overall, you see better flow of the post PCI, I mean pre-PCI TIMI flow, and the timing. If I have to say, the symptom onset to first device time is 175 versus 165, although p-value not different, but symptom onset to coronary balloon dilatation was 200 versus 165 because 30 minutes you had to wait in this. Overall outcome, exactly identical, no difference in the control and treatment group at 1 year, 30 days, or at 12 months. So you can see that exactly identical, both cardiovascular as well as all-cause mortality. And infarct size, again was identical with a 30.8 in the treatment group, 31.9 in the control group. But one of the big thing which happened was kidney injury. You can see here, higher kidney injury, 10% versus 5.8 in the treatment group, and the renal failure, the dialysis was not, other endpoints were not there. But it seems to be that even putting a impella, numerically higher patients went into cardiogenic shock, 2.3 versus 0.4. And the biggest surprise which we got in terms of the age wise, that yes, the treatment impella was a little more beneficial in patients with more than 61 years of age or with a beta blocker administration. But I think this is a minor. But more importantly, or I would say the negative of the trial, until now everything is okay, but look at the bleeding. Major bleeding in the treatment group, 34% versus 6 in the control. Every aspect of the bleeding and vascular complication was very high. Treatment arm versus control, vascular complication, as you can see here, significantly. And patients who have bleeding, we all know, they're associated with all-cause mortality. Those who have a major bleeding and vascular complication, mortality was 31.6. Otherwise, it was 7.4. So clearly, the trial, in my opinion, did not serve its purpose and was negative all the way. Then focus review is the Dynamax bioadapter dynamite PCI study, Dynamax bioadapter implantation, which I have shown, and now we have shown it in the trial. And look at this. Can you increase the volume there? So it is a unique design. Do we have the volume? Tell this guy, wake up. No? Yeah. So basically is that our stents usually are the pure metal. And this is a proprietary design where, that Dynamax has a special interconnecting, you see the interlocks there, and they're covered with the sirolimus and by the polymer. And the polymer, when get dissolved in 3 to 6 months, right? Initially, of course, polymer is there, your drug is released, and basically undergo through the healing process. But then after 3 to 6 months, when there is a resorption of the biodegradable polymer of the stent, you see what happens. This interlocking mechanism, the stent now can be flexible, no longer rigid. And that was the whole restoration of the vessel vasoreactivity is the one important identification of this device compared to our stent, which are fixed. So therefore, we used to do about in the absorbable stent era, bioabsorbable, that we have a vascular pulsatility will come back. But this is the same kind of concept, but still remain the metal. And this is unlocking within the vessel wall. And this is the proprietary mechanism which led to this device, which has been very successful. Plaque reduced, there is positive remodeling in many patients in this using the bioadapter. And the concept, as I mentioned, that people like to have vascular pulsatility, and so earlier data of the bioadapter randomized clinical trial at 2 years have shown target lesion failure very low, like 1.8, target vessel MI and TVR up to 2 years was less than 1%, and this actually has been shown. And what also interesting, that after 6-8 months, the curve is almost flat, and that is what we used to hope after the bioabsorbable stents, bioabsorbable scaffolds, that after the initial, which event continue in the DES, maybe with this new device will decrease. And it looks like the same way. And now we have the data of the Dynamite study. Again, there's no randomization, but all patients together of 53 patients with a 53 lesion, various techniques wise, and by OCT, seeing that stent becomes positive. We have device area 8.15 post procedure become 8.53. So positive remodeling and minimum device diameter increases at follow up. So it's a positive remodeling. That is what we used to expect. And now this is the overall event rate with a TLR of 7.5%. In this complex cases, device thrombosis is less than 2%. And this is the central figure, which puts everything together. That cardiac death and at 9 months and at 24 months very reasonable, and OCT causing positive remodeling, which is the plus point. So therefore, this is the new device. Now it has a CE mark approval, has not come. It's available in India now, and United States, they are putting together to come to United States. They had to go through some randomization or just based on the European data, because we have up to 4 to 5 year data were presented in the Euro PCR yesterday. Maybe next time we'll present this, but overall it's a very exciting technology and plus point in my opinion. Anu, you want to share your yeah,
EYE guided PCI.
okay, show it that.
That's the final picture you can see.
Good, very good. Now
Absolutely
I
pristine
was
and outstanding.
So we actually had a 48 was not covering, so I just advanced it and did 2 stents. 48 and then we put a 12 millimeter 3.5 and 4.0 we went up to 22 atmosphere, but Kiski is saying at the ostial LAD it's barely 5.0, not meeting the optimal imaging criteria. But I think even with 4.0 we went to 20 atmosphere. We don't want to go higher than that. So that is, I think, what the question that we answered. Remember, we saw 360-degree arc of calcium in the ostial LAD. We gave about 4 pulse there. The question is same. We don't know. When you see 360-degree arc of calcium, is it okay or no? One thing we do not understand with the imaging, though, that is, it's a newer imaging, which is deep OCT. Still, you don't see very well. The one we need to understand the composition of the calcium. I know there is all this criteria of a calcium thickness, but there's no criteria of calcium composition based on imaging. If we get that and then do this study to understand, yes, depending on the thickness and the composition, do we give 3 pulse, 4 pulse, 10 pulse, 12 pulse, something more study has to be done. But most of the time, micro OCT or pathology studies have shown that once you've done IVL, you always see some kind of even microfracture in this calcium. But looks like despite us doing 4 pulse in the ostium, Kiski, show it to them, that the stent expansion is not optimal. I mean,
and this is what all the randomized trial of the intravascular imaging have shown. No matter how good you are, how much is the protocol, about 42 to 50% of cases, you do not get all the component of your optimal stent, like minimum cross-sectional area and so on and so forth. And here, in this case, now question always comes, would you have delivered 8 pulses instead of 4 in that area? What could the outcome be different than what we have now? Kiski, tell a little more on the ostium.
Sure. So now this is the left main. Anyway, the stent cover the lesion. So smooth.
Look at the precise placement.
Yeah. So this
Look
is
at
a real
that.
ostium.
Yeah.
And the distal
At
left
the
main
ostium.
area is like 12, well expanded. And now just this is the bifurcation. So come from the 5 o'clock. Just after that.
And you see the nice circ opening, though it is not the ideal imaging, but you see that circ, you see the ostium looks very good. Keep going.
Yeah, so this is just after the circ. So this is definitely ostial LAD. And remember, we had an eccentric calcium like this part. And now the area is like 5.8. So it's well
eccentric
expanded.
calcium and a little nodule there. Possible. Yeah. Okay.
Anyway, the stent is well expanded.
Okay.
No, why are you saying 5.8?
No. It's a later part of the LAD. Keep going. Where was it? You showed 5.0.
Okay, sure. So the mid LAD, like here.
Right there. Remember where we had that arc, say 5.0. Not ostial LAD.
Yeah.
Mid
Not the ostial, yeah. Okay.
Yes.
Even here we went. We did IVL even at this area.
You have the epicranial view? You took the epicranial?
Here we have.
Yeah, show the
epicranial. You can see that's we went 3.5, 22 atmosphere.
Right
there. 3.5, 22 atmosphere.
Yeah. Show the angiogram, please.
Okay. Now the distal reference was what? Okay. So there. Okay. Go here.
Yeah.
Okay. Good.
Outstanding.
Yeah. I mean that area after septal. Probably.
No, septal and just at the level of the diagonal.
Yeah. Angiographically also you see it. There is a 20-30% narrowing. So as much as you can go, we also know you become too crazy, you'll rupture the vessel.
Yeah.
Even with the calcium and stent. but excellent angiographic result of this complex case, and came out with a single stent strategy. That was our plan. Good. So after this, let's just complete our presentation. So we are getting to our time, and so let's go back to the slides again. So basically, our take-home message: randomized, placebo-controlled trial of CTO PCI for angina reduction at 6 months. Thumbs up. The V, which is basically a visual, FFR guided, equal to invasive FFR evaluation at 1 year, and same way FFR angio guided, similar to pressure wire guided PCI outcomes. Both two trials back to back showed similar outcome to our invasive FFR. Then LV unloading by Impala in anterior STEMI for infarct reduction at 1 year. I said 2 thumbs down. One, because no difference in the infarct size. Second, the higher bleeding. And the lastly, Dynamics bioadapter is a unique scaffold design which make a stent metal cage flexible after 3 to 6 months by a proprietary unlocking mechanism when your polymer get absorbed, leading to return of the vessel pulsatility and positive vessel remodeling. Follow-up data are very good, and of course, minimum catch-up. Most important is we need long-term data will establish its role in our PCI armamentarium after undergoing large-scale randomized clinical trial, which are needed in United States, although device has been a CE mark approval. Let's go to 3 questions. One, the true statement regarding the results of the FAST-3 trial, angio-based FFR versus invasive FFR, except similar TVF, similar death rate, similar TLR, higher stroke rate, and lower procedural time. Answer there is no higher stroke rate. It was similar. Second, using the all-rise trial of the angio-based FFR versus pressure wire FFR, similar TVF, similar death rate, numerically similar bleeding, similar MI rate, and lower procedural time. Clearly, the not numerically similar bleeding was much higher, 0.2 versus 0.9% of the major bleeding in favor of the angio FFR, and I do not understand the mechanism for it. Although the time, procedure time was lower in the angio FFR, maybe that is something to do. But overall, there was numerically 1/3 lower bleeding, major bleeding in the angio FFR versus pressure wire FFR. Lastly, the optimal trial comparing IVUS guided versus angio guided PCI of the left main. Sorry. Our third question is, following are the true statement regarding the findings of the STEMI DTU trial, except higher pre-PCI TIMI 2-3 flow in Impala group, higher bleeding rates, lower infarct size in Impala group, higher cardiac death rates at 1 year with Impala group, higher AKI with Impala group. Answer clearly is there was no lower infarct size in the Impala group. And with that, I conclude my presentation today.
Samin, excellent presentation. Anu, great case, outstanding results. So many teaching points you've covered today, and I hope our audience is very grateful for it. Samin, your annual course coming up, convince the audience why they should be attending.
Yeah, so we have now, this is the every month event which we have been doing, but then once a year, we put 9-10 cases, complex cases together, and our focus is calcific lesion. Of course, the left main bifurcations and calcific lesion are some with the Impala support. Those cases will be done with the excellent the input by various our top interventionalists, national and international stature, and we have many dedicated points in terms of the AI in the microvascular field and various secondary prevention strategy. That what do we think will happen in the next few years? So I'm sure it will be very useful, like every year for everyone. We'll have something for all, starting for the nurse tech symposium, fellows course, hemodynamic course, and of course this 9 to 10 actual complex cases.
Anu, final comments by you?
No, I think, can I see? You can hear me?
Yes,
Yeah.
we can.
Okay.
What is
No, I
showing?
think goal is teaching management of calcium and
What's what is showing?
bifurcation. So we try to teach some new points that we have learned using atherectomy and IVL.
And there is the educational apps there. Anu, Samin, thank you. Samin, on a small personal note, I want to congratulate today Elixir Medical and my good friend Alex Nepogodiev. Alex was the person who helped me start the Latin telemedicine program, which created an umbrella for heart attack protection for 100 million patients. Over the last 10 years, I have watched his enthusiasm with the Elixir Medical, and it just tells you how long of work and dynamism you need to develop this. Alex, congratulations. I know 4-year data is also excellent, and continued good wishes. We conclude here, and we'll see you next time, June 16th.
Beautiful.